My name's Ken Montgomery, and I'm with Persistent Systems. We are based in Pune, India, and here in Santa Clara, California. It's always fun to come and speak to a group when the last panel got gifts and before everybody's getting lunch. So that's a great little time slot to be in there. Really excited about this presentation. We're going to be talking about decoding digital transformation in healthcare. And really, I like to think about it as being from IoT to IOB. In other words, we're going from the Internet of Things to the Internet of Beings. And our panel that we have is really uniquely qualified to bring a mix as we address this. What we're seeing right now at Persistent is the idea of digital transformation, this wave of digital transformation. It's now going towards the shore. We're on the back of that now as an industry and as just in general as business. So what's out there next? What are we going to be looking at next? And I think that's what we're going to be able to talk about here. So what I'd like to do is to bring up the panel, and we are going to have some time afterwards for questions. And as I said, the folks we have are a great blend of academics, of research, of public health, of business, and just of expertise. So let me start with bringing up, first, let me bring up Chris Barrett, who's with the BioComplexity Institute at Virginia Tech. Chris? And away you go and have a seat. Now we've got Eliel Oliveira, who is with the Louisiana Public Health Institute and ReachNet. Thank you. Have a seat. We have Anish Patankar, who is with GE Health Cloud. And although I work for an Indian company, I still sometimes have trouble with these. That's why I have to read this. So I've got Paddy Padmanabhan. Let me get this. It's Paddy Padmanabhan, who is an industry expert and has been with a lot of different folks. So come on up, Paddy. Thank you. Sorry, Paddy. I tried. That was my best shot. So first, it's great to see so many folks out here. I thought we were going to lose folks to lunch, so this is just terrific to see. As I said, we're really moving from this idea of the onset of digital transformation, seeing what's coming next. Everyone's using digital transformation, so it almost doesn't mean anything, right? You see this across everywhere. It's like, if I get some new Kleenex, that's a digital transformation, right? So it's like, okay, where are we going with this? When we talk about Internet of Things, McKinsey says that in the next 10 years or so, this has the potential to be a $77 trillion impact on the economy. Now we're in technology, so we're used to hyperbole, right, and statements like that. But when you think about the number of devices that are going to be connected, what that means in terms of data, how you act on the data without getting just consumed by it, and importantly, how you get this data without becoming a data hoarder. Right? If you don't do anything with the data, you just kind of put it in your storage bin. It's not really doing any good. So we're going to be talking about some of that. So first, let me have the panelists introduce themselves and what they do, and we'll go ahead and start with Eliel.
Sure. So my name is Ellie Oliveira. I am at the Louisiana Public Health Institute, and specifically leading the project called ReachNet, which stands for Research Action for Health. And an easy way to understand what this is about, if you know the Obamacare, the Accountable Care Act, and the large fundings and upwards to $30 billion to fund the adoption of electronic medical records, that got all the health systems in the country using electronic data at this point, but that data is not very well organized. So another piece of the Obamacare was a Patient-Centered Outcomes Research Institute, and that institute funded at about $4 billion to basically create the national infrastructure for research improvement. So ReachNet is one of the 13 nodes nationally that basically has normalized data from the electronic medical record to make it usable for research. We probably have about 70 million patients represented inside of the network nationally. 4 million of them are in Louisiana at ReachNet.
Great. Thanks, Eliel. Chris, can you tell us a little bit about yourself and about the BioComplexity Institute?
Sure. So I'm the director of the BioComplexity Institute at Virginia Tech, which is recently repurposed Bioinformatics Institute. The span of the interest is focused on, for the most part, on advanced computation, and but it begins in molecular biology, genomics, genomic analysis, where we work at very basic mathematical as well as biological levels through system biology, population biology, things like epidemiology and so on, through public health. So we have sponsors and customers that range from the Census Bureau to the National Institutes of Health, and we do try to connect from molecules to policy through these computational methods.
And we're going to be drawing some great comparisons on how these two folks, although they don't work together, but how they're approaching things from both a local and a global perspective, which I think is really fascinating. Anish, you want to tell us a little bit about, I think, what's a fairly new organization at GE and what you're doing there?
Sure. So I'm Anish Patankar from GE Healthcare, and we are working on a new initiative called the GE Health Cloud, which is supposed to be an ecosystem of healthcare applications focusing on things like big data, mobility, analytics, and so on. And just like what you said, right, the IoT and hundreds of thousands of devices being connected. In healthcare, if you just see from a GE perspective, we have more than 500,000 imaging devices out there, not to talk about like the EMRs and all the other things. So getting all this data and getting outcomes from all these data, putting it back into the point of care. How do we do that in the most efficient way by building an ecosystem of applications? That's the goal of the Health Cloud.
That's great. Paddy, why don't you tell us, I know you've had a varied background at huge companies and at some startups. Why don't you tell us what you're doing now and a little bit about yourself?
Sure. My name is Paddy Padmanabhan, and I run my own management consulting firm called Damo Consulting. We are exclusively focused on healthcare, and we work with healthcare tech firms and healthcare enterprises with their growth strategies and digital enablement strategies. As Ken mentioned, I've been in healthcare a long time. I've worked in healthcare tech for over 15 years. My last corporate job was with Accenture, and now I work with tech firms and healthcare enterprises across the board, trying to create value at the points where they meet.
That's great. So, obviously we're talking about, digital, we're talking about Internet of Things, we're talking about big data, we're talking about actionable insights that come out of that. I'd like to start with both of you, with Eliel and Chris. Give us an idea of how you're approaching getting actionable information from the different sources that you have. For you, Eliel, in New Orleans and the Gulf Coast states. And then, Chris, we'll have you talk about the global perspective on how you're doing that. So if you want to just...
Sure. So like I was saying earlier, the data that's in the EMRs right now is really not usable from a technology perspective. If you build an application that's trying to make use of that data in an EMR, it's only going to work in that EMR. And even if two organizations have the same EMR, the data is still different between these two organizations. The same brand name EMR. There are thousands of them out there. So what's really key about what we have done through the PCORE project nationally is standardize the data that's out there from electronic medical records. It took about 2 years, $250,000 to get that done across the 13 nodes. But now that the data is standardized in one way, what we can do nationally, we can basically identify someone that qualifies to a specific study. Either can be a pharmaceutical trial or government-sponsored trial. But now you have the data in such a way that you build that query one time by one researcher nationally, and that query can be sent to the 13 nodes, and you know not only who qualifies, if the study is actually feasible to be executed, but where the patients are. That's a very important piece to be achieved. Now, the second thing that we did there is that we found as a big challenge, and is the fact that the data that we are talking about in PCORNet is de-identified. It's actually a limited data set. It contains dates. So we have no names, numbers, social security numbers, or anything. But how, for instance, in Louisiana and Texas, the partners that we have, how do we get to see a whole longitudinal view of somebody's health if you don't have a way to link their records, right? So I have my records inside of probably 3 or 4 different hospitals in New Orleans. So we came up in a collaboration with the Northwestern University with one tool that they have built and piloted with the VA system, where we can match patients across health systems without ever seeing the identifiable information. It's a very powerful feature of what we're doing, and has got the Senate interested in trying to solve the problems that we have nationally in terms of combining the records and more accurately finding who that individual is.
So
that makes sense.
Yeah, absolutely. So that's, to me, it's fascinating because we're really drilling down and being able to see an individual, taking all that information so we understand who that person is, and then making decisions from there. Now, Chris, BioComplexity Institute is almost doing the opposite, which is you're taking this massive amount of data that you get and studying fascinating things from a global perspective and helping policymakers almost in real time make decisions. So maybe you can just tell us, especially with some of the viruses that we have coming out where we might overreact to them, we're able to make more intelligent decisions. Can you tell us a little bit about that?
Yeah, well, we don't want to underreact either.
Yes,
so, right, so the basic approach, just to cut to what the basic approach is about, is to coordinate the integration of data sources around the relevant items in the case of public health and how it's related to patient health. It's at the level of individuals. And so we synthesize aggregating data structures that are granular at the level of every single person. So we have some of these data structures have 7.5 billion individuals and 45 or 50 billion activity locations, and every one of these things is layers of information that are gleaned from all different kinds of sources, of course, but instead of just being regressed over something, they're first synthesized into these avatars and avatar-like locations. It forms like a coordinate system for the integration of information at the level of granularity that's necessary for the processes that we want to look at. So with respect to patients, for example, in EMR, we would produce individuals, synthetic individuals, and we would have information about electronic medical records, and we would have also information about health histories for individuals, and we would produce representative medical records for the health histories they have, because the health record is not a complete history of your health. It's a sample thing that leaves things out, is wrong, is in multiple places, lots of things like that. And you would do this in a way that is granular. On the other hand, these avatars, I can't find you in particular. So from a physician's point of view, from a clinical health point of view, they would provide a synthetic experience of patients that are like you. From the public health point of view, they give you population level granularity that lets you look at the host pathogen environment interaction in really quite a lot of detail and understand things from a public health perspective. It can be used where the items are cells. We have representations of the enteric immune system that are, with 10 to the 10th items that are interacting in there. So it's an interaction-intensive, data-oriented thing. The calculations are done in an application ecology on a middleware that all interact through this data library and views it basically like a fat wire, a wire that the information that's moving between them is not just state here, but in contextually situated information. And we think that it offers a way to tie. You can be fairly, as long as you have API compatibility, you can be pretty app agnostic. You can be pretty problem agnostic, and these kinds of things apply.
That's great. One of the fascinating things that Chris has discussed before is this idea of also understanding health and population in terms of, for instance, Chris, I think you had mentioned that the population of Syria in the last 5 years or so, you correct me, I'm not going to get the number right, but something like 70% of the people in Syria don't live where they lived 5 years ago. and just the type of...
Half of them don't live in Syria.
Yeah, right. Well,
There's a... right, so one of the things about committing to these data libraries is that the data libraries may be the phrase that we can use to describe what it is, but it's very different than, say, a Dun & Bradstreet database that you get a new version of every few months. Once you begin interacting with these, first of all, there's not one for all problems. They're contextually oriented. They can be large. It depends on the problem. And they don't stop changing. So there are issues like in scientific issues, but there's other decision-making issues as well that would have this issue of provenance. If you have to be able to go back and actually determine what the state of the data set was at the point in time that you used it for something. This is a very difficult thing. Well, it's a challenging thing. It's a pretty cool thing too, in this idea of these synthetic data libraries. But it's a way to deal with information systems in very large contexts, where the contexts are an important part of the system, where you don't have a decision maker deciding about a system they're not a part of. I mean, you know, Johnny's mom deciding whether Johnny goes to school or not is a decision maker, and she's in the system. And so is, you know, a lot of other organizations, or so are a lot of other organizations and people. And so the anyway, so I think you get the basic idea. Yeah. So it never stops changing.
So, you know, and Anish, this kind of ties into something that we've discussed before, and I really like how you said this when you're looking at this data and you're looking at this information. You know, it's the two V's. It's variety and veracity, right? Why don't you tell us a little bit about that?
Sure. I mean, I think we touched upon that a little bit, right? The problem in healthcare is not just the size or the volume of data. It's also the variety of data. Patients go to different clinics. They have different EMRs there. So all of that data, it's not easy to collect it in one place to give a good clinical decision outcome. And the other part is the veracity of data. How much can you really trust the data that's coming in? A lot of healthcare is now being pushed out into the home, like infusion pumps and all. I mean, to cut down cost, we say, patient, hey, you go home, you take your treatment at home, and just let us know how it goes. How much can you trust that data that the patient really took that medication at the right time, and the symptom of which the physician is now seeing, to now make a clinical decision to say, I trust that data coming in from all these different sources. So big data in healthcare is not just about the size, it's also about the veracity, the variety, the disparate nature of it, all of it coming together, and then tying it back to when that decision has to be made, when a physician is actually recommending what is the next best course of action for this patient. So these challenges are a little bit different for healthcare, and you cannot just apply the same technologies that you would do in other places, right? So you have to take all of these things into account from a technological perspective, the patient behavior and all these things. So it becomes very important to make sure you take that holistic view of taking the data with a very different angle for healthcare. And
so just, you know, briefly tell us how GE with this, you know, the idea of, you know, the GE Health Cloud, how are you, again, briefly, how are you kind of building this ecosystem, you know, that addresses that? Right,
so I mean, the holy grail for healthcare right now is precision medicine, right? What is the best treatment you can prescribe to this one patient who's coming to you, right? With that background, with this genotype, phenotype, with this chronic conditions, the doctor wants to recommend the best treatment for this one patient. But in order to do that, you have to analyze tens and thousands of patients, what has worked for them, what has not worked for them, given their backgrounds, their chronic conditions, and so on. So you really have to go digital. You have to go industrial in order to go personal. And that's sort of our goal here, is to analyze lots and lots of data, curate it, analyze it, and then figure out what will work best for one patient in one situation. And just as a quick example, right? I mean, we get brain MRI scans from thousands of images from thousands of devices, right? Now, when you get the next scan, you have all this data repository. You can scan it, and then you can predict the likelihood of this patient getting Alzheimer's or dementia in the next 5 years is so and so. But now you're just looking at brain MRI scans. What if you now tie it to the blood reports you have, the genotype you have for that patient, the allergy reports, everything else, And all of this data being spread out, you can collect it, analyze it, and you can just deliver such a better outcome for that one patient. So that is sort of as an example, that is the sort of thing that we are going after.
That's great. Paddy, just before I get to you, what you've touched on is something that, Eliel, what you're doing is so crucial, right? The idea of the veracity of the information as you're working with your patient community. How do you guys address that? How are you able to address that?
So I think what we are hearing here is that the data that's there needs to be validated, needs to be trusted in healthcare. And the data, the way that it is across the country, is not really normalized. Getting to that place where we are, at least in the network we have been building, allows you to be able to pinpoint things and take you to the next step. Like you're talking about the precision medicine initiative. One of the premises of what PCOR is trying to do, this project, is basically reduce the time that we can find answers for a specific research question, like you described. So it can take about 10 years to study a specific challenge in healthcare and find out what really works and doesn't work. But what we are trying to do is not only change the amount of time that takes to find that answer to 10 years to maybe 5, but also dropping the cost from a quarter of what costs today. Very efficiently execute research, find answers, and then feed that back to the health systems so that they can change their practice and consequently improve the health outcomes.
That's right. So Paddy, I mean, you're kind of the sage on the panel here. What is it that you're seeing right now? Like, what's the exciting stuff that you're seeing that's going to really be driving this as we move forward?
Right. Firstly, I want to mention that it's very appropriate that the theme for this conference, or the name for this conference, is Confluence, because we're seeing a confluence of some very important factors in healthcare as it transitions from what used to be a fee-for-service model or a piece rate model to what is effectively now going to become an outcomes-based and a value-based reimbursement model. So some of these forces that are coming together are digital, analytics, mobile. Everything is mobile right now. All the experiences are mobile. And the quality of the experiences is becoming extremely important from a patient and a provider standpoint. Analytics fits kind of front and center into all of this. And my co-panelists have talked about all the data sources, the data types, and so on and so forth. So all of that is real. All of that is happening. At the same time, I think there's also been some recognition of some of the challenges in working with patient medical information because of privacy concerns, because of a lot of HIPAA and regulations, and so on and so forth. So it's not as straightforward as it could be in something like retailing, where you're really targeting an individual with an offer or a coupon or something. Like, you just can't do that easily in healthcare simply because of privacy and regulatory issues. So that's one. So I see a confluence of all of this, and people are moving towards a value-based system in their own way and digitizing the experience. A lot of things ride on it: the reimbursement rates, the reimbursement amounts, penalties, on the other hand, if they're not able to deliver the right kinds of experiences. The other thing that I'm seeing at a macro level, and we're in Silicon Valley here, and we tend to think, about disruption and innovation as necessarily a startup-driven phenomenon. I'm actually seeing the exact opposite in many ways. I'm seeing the big companies are doing some very, very interesting things. GE Healthcare, we just talked about GE. At the recent CES show, we saw this IBM Medtronic partnership for this diabetes monitor, phenomenal case study and use case. I've seen interesting examples like Quest Diagnostics and Invalon. We talked about data. Quest has 20 billion lab test records. You can't touch that. Who's going to have access? Who's going to create 20 billion records overnight? No one. And when they combine that with, when they leverage that, and when they look at the highway that they've already paved with all of their hospital systems partners and so on and so forth, and they unlock the value of 20 billion records and combine that with claim records, from a bunch of, Blue Cross Blue Shield plans and so on, then you start really talking about a holistic view of the patient, which is longitudinal, which also has breadth, and now you can layer on top of that, IoT data, wearables data, demographic data, and so on and so forth. I also want to mention that this healthcare is a hard nut to crack because of the nature of the industry, and I think startups are realizing that it's not just a question of spinning up a model and going with it and raising some money and calling yourself a unicorn, because we've seen a couple of unicorns in serious trouble, healthcare unicorns, and that's a topic for a separate discussion. Yeah.
So let's talk about some of the technologies that are coming down that are really starting to gain traction. And I'm thinking of blockchain, right? I'm thinking of TensorFlow. I'm talking of like virtual reality. We've talked about pilots when they train in virtual reality simulators, right? We don't send pilots up into the air of the train. Let's just open this up to whoever would like to take it. Let's take. Why don't we start with virtual reality? Who would like to take that?
I'd like to take a version of it that isn't virtual reality, that's synthetic experience, that when a patient presents in front of a physician in a classical environment, an experienced physician has the benefit of seeing many patients with those characteristics, and in addition to what you can get in books and stuff, their diagnostician selves are influenced by that. But if you can look at 10,000 avatars that have assimilated all this information and characterize a population of people that, for one reason or another, this real individual is indistinguishable from, and you have fairly complete constructed health histories associated with them, and things you can search and look for, and hypotheses you can test. You're in an entirely different informational environment than simply big data. Okay, it isn't. It's completely different. It's organized in a way that presents you not just with memory, not just with access to data, but with experience, with the sum total of an aggregated experience that is new, which is really what the thing about the normal virtual reality is that you can perform experiments and you don't have real consequences, when they go wrong before you commit. And that's different than what I'm talking about here, but it's related in the sense that I just wanted to, first of all, there's data issues here, like in trials. There's blind issues in trials, which means you don't have access to data on purpose, or you compromise the experimental design. You compromise the process of learning by making data available to the patients that are receiving these treatments in blind trials. This is very unlike other kinds of quality treatments for data. This is, by data suppression, you maintain the integrity of the information that you gain and the knowledge that you. This is a very difficult thing to get your head around from the point of view of informatics support, especially if you assume that all the data you get is true, except for maybe an error function that's like a measurement error. Because we're not talking about measurement error. We're talking about, in this particular case, a very intentional thing. But there's pharma issues. There's all kinds of issues where information may or may not be exactly what you think it is, and the synthesis process is potentially valuable for that kind of synthetic experience.
Yeah, that's fascinating. And I don't want this to sound like a commercial, but Chris is a customer of ours, and we just published a video about what they're doing. If you go to our website, persistent.com, you'll see it. And it's really fascinating. If you talk about a absolutely apropos named organization, just the complexity of what's going on there. So it's fascinating. Paddy, what else are you seeing just in terms of future technologies out there as you go and talk with folks? And
healthcare is, I wouldn't say healthcare is kind of at the bleeding edge of technology in general, but there are, but the opportunities for new technology in healthcare are huge. So now it's going to start at the edges. You'll have some of the more progressive organizations, the academic medical centers, the Johns Hopkinses of the world. They'll do all of this stuff first, and they will kind of pave the way for the followers. And I think 30 billion or whatever has been spent on laying the data foundation over the last several years, and the unlocking of the value of the data is just about beginning, right? So in the coming few years, we're going to see that data being leveraged in ways that are going to truly transform our healthcare system. I think To me, that is the one big, massive macro level phenomenon that's taking place as we speak. Now, there's all kinds of other moving parts, the wearables data, how usable it is, how reliable it is, and all of that. But, all of that will get addressed as we go along.
So as we start to wind down, I feel like we could just talk for a couple hours up here. Because it's just, it affects all of us so much. Let me ask if you can give just me a very quick answer on this. What's one thing that you really hold that we can do now that just wasn't possible, say, just 10 years ago, right? That's made an impact. Why don't we start with you?
With me?
No, well, we go. I was going to do Anish. Anish, let's start with you.
So, I also want to just add to what you just said, right? I mean, from my perspective, it's deep learning. Just the unlocking of all this data. I mean, in the last 10 years, because of meaningful use and all these things, everything has been digitized. And in some cases, this has made things worse because there was a mandate to digitize everything without the mandate to share that data. So everything is now locked in its proprietary systems, but that data is now available in a digital format to be ready to be harnessed. And we have variables data, all these other things coming into the play, right? So the big thing is, once that data is unlocked, what do you do with it? Yeah. And applying deep learning for different kinds of things. I think that is sort of, it's not as consumer-facing as virtual reality and all these other things, but I think that will have the biggest impact on healthcare going forward for precision medicine, for better outcomes, for reducing costs, and all of these things. And I think that's where and that's why it's difficult for startups to do some of these things, not because they don't have the technology, but they don't have access to data, they don't have that domain. And then bigger companies are in some ways better positioned to leverage this disruption for healthcare. And then big data and deep learning on top of it, I think, is where we should all be focused on.
That's great. Eliel, what do you think?
Sure. I think that there is a tremendous opportunity there. We talked about the EMR adoption, but one thing that I would say right now, as an example, is diabetes. It's a $250 billion problem in the country. Mm-hmm. And if you know anything about it, it's not about taking any drugs. It's about changing somebody's behaviors. Right. And that's a huge opportunity in my mind in terms of IoT and in applications in terms of how you can affect people's life in such a way that they'll change what they're doing to be better. The big challenge then at this point here is how do we get to an environment where developers can get to develop these applications and open the market from healthcare. It has been very closed to anybody out there that can develop. So watch for something as FHIR, the fast healthcare interoperability resource, which is a protocol for data communication that's basically getting the health data exposed as APIs, JSON format, XMLs, where any developers can now come to the table and build new, interesting things that can solve real problems. But again, I'll go back to what was said here. These startups, these companies, they need to figure out that they need to partner with physicians, with healthcare, with practitioners, with patients and caregivers to actually build something that's designed beautifully and really solve problems.
Anand, were we going to take questions from the audience? I'm sorry?
One question.
Okay. So we might have just, does anybody have a question? I think we have just time for one. Yeah, we have one right here. Good. Let's wait for a microphone.
Yeah. So my question is today, there's so many IoT devices collecting all kinds of data, right? So how do you guys handle privacy issue around data collection, especially in GE side?
Right, so it's a very big problem, right? This is one area where I think having HIPAA and privacy laws is sometimes sort of an impediment to sort of further the betterment of healthcare. So there's different ways to tackle this. I mean, sometimes it's individualized, it's different in different countries. To get data to the cloud, I mean, from a HIPAA perspective, sometimes you have to make sure the data is anonymized, meaning the patient identifying information is left behind and only sort of the de-anonymized information is brought in, aggregated, and then you run your deep learning algorithms on top of it. So that's one way to handle the problem. The other ways are that you keep data localized and you take your analytic to where the data is and then collect the results and then aggregate that. So that's another way to do it. And in some countries where the regulations are not as strict outside the US, it's a little easier to handle that. So it's different in different places, and depending on what you really want to do, we are looking at it in different ways.
Right. Just I have a follow-up question on this, right? So when you collect the data, you're collecting at some location. In, like, for example, you're collecting in California, and then you may be storing the data in a different place in a different state, right?
Right.
And you may be accessing the data in a different state,
right?
So how do you handle all the different state rules? When I say state, it also includes the countries as well.
Right. So we have to. I mean, the one thing we cannot change and we comply with at like very forcefully is the local regulations that are in place, statewide, countrywide, and so on, right? So for example, in the US, we have to make sure that if we are taking data to the cloud, it has to be within the US itself, right? Same thing for Canada, same for UK and Germany, and so on. So we have to make sure that the patient data for that country stays in that country. But if it's de-anonymized, we have a little bit more freedom to sort of take it outside and do things with it, right? So we have to use those kind of parameters, keep that in mind.
Thank you.
Well, I think we're out of time. I seriously, I wish we had another hour to spend, because I think this is so interesting. I also think this panel, we talked about, is this blend of public, of research, of business, and we also just on this panel, it's just the global economy, the world being flat. We have people from India and Asia and South America and the US, and I think this is the way of the world, and I think it's just great to see. So thank you guys very much. Thanks all of you for holding off on lunch to listen to this. Thank you.